Bronchoscopy is usually performed to help diagnose and treat a lung problem. Some of the most common reasons are to obtain samples for testing in the laboratory, to examine the lining of the lung, and to determine the origin or cause of bleeding, and to investigate abnormalities found on X-rays and CT scans. The bronchoscope is a thin, bendy tube which has a light on it. There is a narrow channel in the bronchoscope through which the doctor can remove samples from the lungs. These samples will be sent to the laboratory for analysis. Preparation is required before the procedure. It is important to clarify the use of diabetic or anticoagulant, which is blood thinning medication, and their use prior to the procedure being performed. Your doctor will check any blood or breathing tests performed usually prior to the procedure. For example, warfarin INR check is usually requested the morning of the procedure for patients stopping warfarin. Patients are required to fast prior to the procedure. Your doctor will advise you in relation to this. Normally patients can take their other medications as planned, but again, this will be clarified when the procedure is booked. As sedation is used, patients will not be allowed to drive following the procedure, and we would recommend that they attend with another person and that they stay with someone overnight until the sedation wears off. Check in at the reception desk and present your appointment letter if you have a copy. The nurse will bring the patient to a bed in the department. The nurse will then complete a pre-procedure care plan and observations. The consultant will review the patient's radiology imaging, X-rays and CT scans, as well as their pre-procedure blood and breathing test results. The consultant will then complete the consent process outlining the indications for the procedure, sampling methods, and risks and benefits. The patient will be asked to sign a consent form and given a copy of this. A Venflon will also be inserted. An electrocardiogram or heart tracing will also be carried out if this has not already been performed recently. The sequence of patients undergoing the procedure is determined by staffing numbers, the tests required, and infection control considerations. The patient is then moved from the recovery area to the endoscopy room. Nursing staff confirm the patient's details, allergies, and their understanding of the procedure. The patient then has 3 cardiac monitoring leads attached to their chest and an oxygen saturation probe placed on their finger. Nasal specs to deliver oxygen are placed on the patient's nose. The consultant will administer a small amount of sedating medication into the vein using the Venflon. This is usually a combination of midazolam, a Valium-like drug, and alfentanil, a morphine-like drug. This medication makes the patient sleepy, and some patients do not remember what happens during the procedure. We do not use a general anaesthetic. It is called conscious sedation. This can sometimes cause amnesia. The back of the throat will be sprayed with local anaesthetic. This freezes the throat in the same way a dentist uses local anaesthetic. The patient may feel they can't swallow, but they still can. Any excess secretions will be removed by the nurse using a suction catheter. The consultant will also inject local anaesthetic directly into the windpipe. This will usually cause the patient to cough, but will quickly settle. A mouth guard is inserted to protect the patient's teeth and the scope. Please inform staff of any loose teeth or dentures which are at risk of damage. Additional sedation is administered intravenously until the patient is adequately sedated and comfortable. The scope is then inserted through the mouth and passed down the windpipe, spraying local anaesthetic as it is passed to freeze the airways. The throat can feel a little sore following the procedure. The consultant will then inspect the airways of both lungs. Any sampling is then performed. Bronchial washings. A small volume of sterile water called saline is passed through the scope into the lung, allowed to disperse, and then aspirated or sucked back and sent off to the lab. Bronchial brushings. A small brush is inserted through the scope and is used to brush cells off the lining of the airway walls. Bronchial biopsy. If an abnormality is seen, a small bite or biopsy of tissue is taken. It is not painful, but the patient may be aware of a tugging sensation. It can cause bleeding, which would usually settle on its own. Transbronchial biopsy. Sometimes we take biopsies from areas of the lung which appear abnormal in scans, but which cannot be accessed directly by the scope. The biopsy forceps are passed into the region of interest and samples are taken. This can cause bleeding, which would usually settle on its own. Sometimes if we are taking biopsies close to the surface of the lung, there is a risk of causing air to leak between the lung and the chest wall, called a pneumothorax. Needle biopsy. The scope we use also has an ultrasound probe on the tip, which allows us to see structures such as glands or masses lying outside or adjacent to the airway tubes. We can then biopsy these areas under ultrasound guidance using a thin hollow needle. Again, this can cause some bleeding, which will usually settle on its own. Bronchial lavage. Sometimes when there are areas of infection or inflammation in the lungs, we use a larger volume of fluid between 100 and 150 milliliters to perform a washing or lavage to obtain a larger specimen for analysis. This can cause the patient to experience a fever temporarily following the procedure. Potential complications. Because we give people sedation for the procedure, it can make them sleepy, and this in turn can lower their oxygen levels. This is why we give people oxygen during the procedure and we monitor their oxygen levels throughout. If a patient's oxygen levels were to go very low, they may develop an abnormal heart rhythm. We also monitor the heart rhythm throughout the procedure. If a patient were to develop low oxygen levels or an abnormal heart rhythm, we would stop the procedure. Sometimes patients do not tolerate the procedure. They may cough too much or gag. Some patients may undergo the procedure, but the results may be inconclusive and additional tests or a repeat procedure may be required. As with any procedure in which intravenous sedation is used, some patients can become unwell during the procedure. It is unusual, but it can happen. It would be very unusual that a patient would become so unwell during such a procedure that they would die. This has been reported as less than 1 in 2,500 cases, but is something which we are required to inform every patient of before the procedure. Once all samples have been taken, the scope is removed and the procedure is completed. The patient is disconnected from the monitors and transferred back to the recovery bay on their bed. Nursing staff continue to monitor the patient for approximately 30 minutes following the procedure. The consultant will speak to the patient and relatives following the procedure to explain the findings, samples that were taken, and further management. Most results are available 1 to 2 weeks, but some samples can take longer before final results are available. For example, tuberculosis culture samples can take 6 weeks before a negative result is reported. Patients are given an information booklet, What to Expect After Bronchoscopy. The persons who accompany the patient to hospital are contacted when the patient is ready to go home. Patients are advised not to eat or drink for 3 hours following the procedure, as their swallow is impaired due to the local anaesthetic and intravenous sedation used. There is a risk of food or fluids going down the wrong way into the lungs, called aspiration. Patients cannot drive following the procedure, and we recommend that they stay with someone overnight until the sedation wears off. Patients are usually followed up in the respiratory outpatient clinic in a few weeks' time.